Okay. Thank you very much, Dr. Vijayan, for the very kind introduction. Good morning, everyone. Okay, it's a pleasure to be here for the second time. Last year, I was here to speak about survivorship and palliative care. And this year, I've been given the task to talk about building hope and empowering lives through the lens of palliative care. Before I explain about what palliative care is and what we do, first and foremost, I would like to thank the organizers for inviting me and also for recognizing that palliative care actually does have a role in patients' care, be it for cancer patients, where we are discussing about that matter today. And we are also involved in patients with life-limiting illnesses who do not have cancers too. So it's not just cancer patients who need palliative care. But the needs are very much recognized in cancer patients, where nowadays we have a lot of different modalities and types of treatments that allows our patient to have better prognosis. But it may not necessarily change the cause of the illness itself over time, and our patients will still have a lot to endure in terms of symptoms control, in terms of psychosocial issues, and sometimes spiritual issues too. And that's where we come in for our patients. So about palliative care itself, I hope for most of you, you have recognized this definition that was outlined by the World Health Organization way back in the early 2000s. So palliative care is an approach that helps to improve the quality of life, not just for patients, but for their family members too, who are facing any problems that are associated with life-threatening illnesses. And we do this by trying to prevent and also relieve any form of suffering that patients may be experiencing. And we do that by identifying what those problems are for these individual patients, as well as a proper assessment. And then we help and treat some of the physical symptoms that these patients are experiencing, usually pain, but it can be a lot of other symptoms too. And we help to try and address any psychosocial matters that may be involved with their care, as well as give them as much as spiritual support that we can, as long as we are trained to do so. Did any one of you find the word death within that definition? No. Did any one of you see the word end of life in that definition? No. But sometimes when people refer to us, they use those words. And what do you think patients feel when you use those words when you refer to another doctor? They will be scared, isn't it? Not any one of us in this room who's not scared of death. I think all of us are, no matter how calmly we think about the matter. And another thing that also got me frustrated sometimes is that when other healthcare professionals start using the terms, there's nothing else we can do, and then giving that referral letter, maybe you should go to palliative care. That makes us sound a little bit like Harry Potter, actually, because we don't do abracadabra or whichever other magical form of things that they do. What we do is try to provide support. So please, please, please refrain yourself from saying there's nothing else you can do. There's nothing else we can do. There's a lot more that we can do, as long as we recognize what our roles are within that space. So what about hope? How many of you have seen the movie Shawshank Redemption? Oh, not many. Okay, there's a few up there. Thank you for being one of those from my generation. It's one of my favorite movies. I list it as one of the top 5 of the movies that I like. What I like in that movie is the contrasting picture of hope that was given by Red, as you can see here. His name is actually Alice Redding, but nobody calls him that in that movie, so everybody calls him Red. And somewhere at the start of the movie, Red said this: hope is a dangerous thing. Hope can drive a man insane. Which is not entirely wrong, actually. And if you think about it, hope makes us do a lot of things that may not be rational sometimes. But I hope in this talk, I'll be able to explain to you about how hope can be a very positive thing, and how hope can still help to drive our patients in terms of the time that they have left, and in terms of an in terms of experiencing the illness trajectory, whether or not curative options are still available for them. So what is hope? The dictionary will tell you that hope is to cherish a desire with anticipation, to want something to happen or be true, or to have a desire with expectation of obtainment or fulfillment, and to expect with confidence. I don't have to tell you all that for you to already kind of know what hope is, isn't it? Yeah. Here's where we can have a little bit of a problem. Healthcare professionals and patients do not view hope as the same thing. For a lot of us in our medical line, we see hope as cure. For a lot of us, we see hope as a tangible treatment, something that we can give to solve the situation for an outcome that is important to us, not necessarily the patients. What's the issue with this? The issue with this is that we start researching on outcomes that are quantifiable with a set of measurements that are actually decided by the healthcare professionals. We look at disease-free timeline. We look at survival curves. We look at survival time. Did any one of us discuss about what happens during that time that they are taking medication and still surviving? How many of them lose the job that they were holding on to? What kind of financial toxicity the treatment caused them? Not necessarily, isn't it? What about their family members? How many of them have to quit work to look after them? What kind of care do they get? What kind of symptoms do they experience while taking all the medications that we told them is going to bring them good? That leaves us a big question mark, isn't it? If you look at hope theory, they look at hope from three different perspectives. The goals. The goals vary in terms of number, specificity, time orientation, as well as valence. They also look at pathways. These are the different multiple pathways or strategies that we can put in place so that we can try to at least be closer to what our hopes are. As well as agency. These are the actual willpower that patients and their family members may have in terms of keeping that hope in place or trying to find out what is realistic and what is not. I'll give you a case study. Mr. NJ is a 71-year-old man, and he was diagnosed with colorectal cancer sometime in 2021. He underwent resection, and stoma was created, but he declined chemotherapy. About a year later, he presented with abdominal pain, lethargy, and anemia. CT scan confirmed that he now has recurrence. Initially, he was started on morphine, and then he was started on regular fentanyl patch for pain control. And he had one admission to the ward with fluctuating stoma output. Does this sound like somebody with a good prognosis? Not really, isn't it? It sounds like he has had intervention to his cancer before. The cancer is now back, and it's now causing a symptom, a problem that can be life-threatening, isn't it? So we look at his case from the palliative care side when he was referred to us. He had problems with shortness of breath. He had problems with pain that was easily managed with fentanyl patch as well as morphine. Then we started talking about his psychological as well as his spiritual ways of coping. He understood that it was more difficult for him to undergo treatment. He had actually understood that from the very beginning, because after the surgery, he has already told the doctors that I do not see myself at this age as someone who goes in and out of the hospital for chemotherapy. I've got good and loving family around me, and I know they will care for me, and going in and out of the hospital is not something that I view myself as at this point of time, is what he said. And then we asked him, what is most important to you at this point? This is the magical question that we normally ask patients when they come to our clinic. What is the most important to you? This is probably the closest we get to Harry Potter in palliative care. And he said the most important thing is for him to be able to spend more time at home. And why does that matter to him is because he had 5 children, and the last one was getting married. The other 4 already have their own families, and he had grandchildren from the other 4. And this last one is a marker that he has made it in life. His responsibility is done. Yeah. And we heard him. Whether or not we are able to help him, that's the second question. Then we sat with the family member, very good social support. They all don't really stay in the same state, but they know how to arrange a schedule so that someone is there with the mother to help care for the father. Carer was identified, the wife and the children, and we also referred him to our hospice colleagues to help and see what they can help with in terms of support at home. So we explored his hope and wishes. The reason why he didn't want any further chemotherapy was that he had a long stay following his surgery. And he knew himself that his body was not going to be able to withstand all this difficult treatment that people are offering to him. That if the surgery took him that long for him to be discharged, then having more and more chemotherapy would mean more and more days in the hospital, and that wasn't important to him. Yeah. His priorities is for more time with the family, for as long as he's there. Because in terms of his life, he feels like most of the things he has achieved. He's only got that one thing. The last one is getting married, and he needed to be there when that happened. And he also knew that his family will look after him when he's at home. Yeah. But just discharging him wouldn't be a solution, isn't it? He needs very good medication. He needs very good support. Their family needs good medication and support too. That's how we try and help them. The thing about hope is that the common denominators that we normally see when people talk about hope are the expectation of a better future, the strong affective component where we feel things about our hope that is related to our emotions too, the desire for something which is good and positive. He knew where the cancer was going, but did he say anything about what the cancer was going to do to him? No. What he said was what he hoped for his children, his grandchildren, as well as his wife, that they have support in terms of caring for him too throughout this very difficult period. And also the life experiences that they get with their loved ones around them. That matters more than what was going to happen with his cancer. So what is hope in palliative care setting then? Because if we don't understand this, we're going to start telling our patients that there's no hope left for them. Hope in palliative care setting can be present at all time. They can be present at the start of diagnosis. They can still be present at the point when patients are on their deathbeds. And having a terminal illness do not actually diminish the hope that you have. And it's actually a positive coping mechanism. Should we be removing a positive coping mechanism that our patients have? We shouldn't, but we should find the right way to support them with the hope that they may have, whether it's realistic or not. And it's not our place to say whether such hopes are realistic or not. Our hope is to support that hope for as much as we can. And they're not only limited to cure. That's our definition as healthcare professionals. For most of the time, that's not what the patients are looking at. So for a lot of them, it may change over time. The hope for cure can change to hope for less suffering, for reasonable quality of life. And hope increases well-being and improves quality of life and allows patients to find solace in adverse situations. Remember just now what I told you about the definition of palliative care is to improve quality of life, isn't it? So shouldn't we be working with something that also improves the quality of life for our patients? We should. And it also enables patients to appreciate the meaning of life, something that makes them stronger in terms of their spiritual self too. So if you can understand what palliative care is, we should be introducing palliative care early when patients are diagnosed with advanced cancer. Over time, we do a lot less of what we call curative care or disease-modifying treatment, and our involvement in palliative care would be a lot more as the disease progresses over time, before we get to end-of-life care. As much as possible, we also try to help the family members and their loved ones throughout the bereavement visits. Although we are not able to help every single family members at this point, we try to identify who needed more support than others. And hopefully, we recognize that at the start, they may be hoping for a cure, but after some time, these hopes change over time. And that's okay. That's not losing hope. That is actually the dynamic nature of hope when things change over time. We look at Malaysian patients. This is a study done in Malaysia. What they found was that there are different themes of hope containing the notion, the sources and barriers, and the content, hope to be, hope to do, and hope for others. What they also find is that we should not say those things like there's no more hope for you, there's nothing we can do for you. we should be present with the patient and support them in any kind of problems that they may have. And the hope is usually subjective. Patient can still be contented and at peace despite having adverse situations. There are a lot of ways where we can foster hope, but the most important thing is open communication and being able to really listen to your patients. Some useful phrases, maybe, we try to hope for the best, and every doctor will still hope for the best, but try to be prepared for the worst too. Deterioration is not a sign of weakness. It took a lot for you to get to this point. As well as getting help for care does not mean you're a burden. It actually is a sign of love that everyone around you have. I'm coming very close to the end. Our time is actually up, but I'll tell you what happened with Mr. NJ. When disease deteriorated with bowel obstruction, we started him on infusion medication and instituted a terminal discharge plan where we put everything in subcutaneous infusion and also taught the family members on how to use subcutaneous medication for per needed basis for any uncontrolled symptom. He managed to be there for the last child's wedding. He didn't actually go to the wedding venue itself, but everybody came over to see him, including the married couple. And he managed to see everyone that he cared about on that day, and he managed to be there with his family members. He was cared for by the PCU team as well as hospice team for about 2 months. Over that period of time, he only had one admission to the hospital for about 1 week for us to decide what would be his subcutaneous infusion doses before he goes home to be with his family members. And for us to be able to get good end-of-life care, we need to talk about hope with our patients. We need to talk about hope with their family members, and we need to refrain ourselves from imposing what we believe about hope based on our definition. So hopefully I've concluded to you that hope is dynamic. It's there all the time, even though you're at the point where your disease is unable to be cured anymore. And it's subjective. You need to find out what the definition is for the patients and the family members. And for you to do that, for us to do that better, we need to build trust and improve our communication too. Last thing, this is the quote given by the other person in the same movie. Remember, Red? Hope is a good thing, maybe the best of things, and no good things ever die. Thank you very much.